So I'd like to introduce our next panel. First, I'll introduce our moderator, Vinnie DeMarco, seated at the end, a longtime advocate for public health causes, including a lot of creative ways to expand healthcare coverage through smoking taxation. He's in charge of, there's so much you could say about him, but currently spending a lot of time with Healthcare for All for Maryland, which is very active in assuring the full implementation of the ACA in the state of Maryland. You heard about upcoming events from Stephanie, and I think these efforts, while not particularly targeted to the Latino immigrant community, may help, rising tide helps all ships. So thank you, Vinnie. And then our two panelists, Lena Hershkovitz, sitting closer to me. She oversees insurance eligibility and enrollment for Healthcare Access Maryland. HCAM is a nonprofit agency that connects residents to public health coverage and then helps navigate services. In 2013, HCAM began serving as the connector entity for Central Maryland, partnering with the state of Maryland and local organizations to enroll individuals in health insurance under the ACA. And seated next to her is Shannon Mace-Heller, the director of the Office of Policy and Planning for the Baltimore Health Department. She oversees legislative affairs at the Health Department and leads departmental efforts to address the social determinants in health. Of particular interest is also her involvement in medical legal partnerships. So we'll start with Lena, and then she'll pass it off to Shannon with questions at the end moderated by Vinnie. So thank you.
Thanks. It's working, so just the arrows. Oh, okay. Yeah, oh, perfect. Okay, thank you. Good afternoon. I'm Lena Hershkovitz. I'm the VP of Eligibility Programs for Healthcare Access Maryland. And as Sarah said, we are the Central Region Connector. So we have a grant from Maryland Health Benefit Exchange to have navigators serve the Central Region of Maryland, which is Baltimore City, Baltimore County, and Anne Arundel County. In FY16, we'll have 2 partners helping us do that work. We also work with the local health departments and the local departments of social services in our region. We employ navigators who provide outreach and education, conduct eligibility determinations for Medicaid and qualified health plans, and then facilitate enrollment into Medicaid programs as well as help selecting a qualified health plan. We also act as the local health department for the processing of Medicaid applications in Baltimore City. So we have about 35 caseworkers in our office who right now are processing income and identity verifications as their main role in Maryland Health Connection. So as you all probably know, the eligibility and enrollment system right now for the majority of enrollment, Medicaid and QHP, is marylandhealthconnection.gov. And on this system, consumers can have their eligibility or medical assistance for eligibility for medical assistance or subsidized and non-subsidized qualified health plans determined, and then they can enroll into a QHP during open enrollment or during a special enrollment period that's triggered by a certain qualifying life event. But there are certain things that they cannot do on Maryland Health Connection, which is what I'm going to discuss. So the first is they cannot select a Medicaid managed care organization. That still happens the same way it always did, where Health Choice, the enrollment broker, will send a packet to the consumer for them to select a plan. And if they don't select a plan in the given time frame, they will be automatically assigned. And they also cannot apply for non-MAGI Medicaid programs. So that includes emergency Medicaid and Medicaid for age, blind, and disabled categories. That still occurs in the legacy system, CARES, and has to be processed at a health department or Department of Social Services. So the reason why I was asked to speak is to talk about some of these barriers, especially for households where there are mixed statuses. I think most often we would see where the parents do not have social security numbers or are not citizens, but their children are. And so this leaves them in kind of a conundrum, where do I go for which programs? And so these system and process process changes are confusing for everyone. So it's not just you, it's not just your consumers, it's actually even the caseworkers, though they might not want me saying that. There's a lot of policy questions that are not clear regarding immigration status and how it impacts eligibility. I know that there's a lot of confusion as to where the intersection is between Medicaid and qualified health plans and who gets what. And then also where consumers should go for services. So, you know, all of the entities that I listed, connector entities, local health departments, and departments of social services are supposed to be functioning as a no wrong door. But what we're hearing is that people are turned away for seeking certain programs at certain locations. And so that's created a lot of confusion in the community as well. And so the overlap of the legacy system, which is CARES, which is what has always been used to determine Medicaid and is still being used to determine emergency Medicaid, and then the new system, Maryland Health Connection, is really the most relevant in households with mixed immigration status. So for Maryland Health Connection, that can determine insurance eligibility for Medicaid and QHPs based on a consumer's income and household information in real time. So you put in your information and you get an immediate determination about what it is that you qualify for. And if it's a QHP, you can go on and select a plan. So you could, in theory, do this all in one sitting. However, those applying for emergency Medicaid, which, as you know, covers labor and delivery for pregnant women without Social Security numbers, must still do that via paper application, which is processed in CARES and therefore takes 10 days at a health department or up to 30 days at a Department of Social Services. So that's just one major difference. Oh, and I did forget to mention that if you have a household with mixed status and you're going to apply for children, for example, on Maryland Health Connection, those in the household who are not citizens must also be included on the application, but listed as not applying, even if they don't have a Social Security number. So that's another piece that does cause confusion, is that everyone in the household still has to be listed, even if they can't actually access health insurance through Maryland Health Connection. So again, this is especially difficult to navigate for households in which one or both parents without Social Security numbers are applying for their children who were born here in the United States, because it means that they have to apply or renew their children's insurance on Maryland Health Connection, include themselves as not applying, and then if they are pregnant or seeking coverage, emergency Medicaid coverage for themselves, then there's a separate process which involves a paper application that takes longer to process. So what this means for your clients is that there are a few barriers to using Maryland Health Connection that you should just be aware of and probably are already aware of. So renewals and applications have to be done online, and this is a new process. I think most consumers who have accessed emergency Medicaid or regular Medicaid in the past are very familiar with going to the health department, filling out a paper application. When it's time for a renewal, they're going to get a form in the mail. All they have to do is review it and sign it and send it back, and that's their renewal. Well, now it's a whole different process that involves completing the application on Maryland Health Connection, and even though the system is available in Spanish, I think most people, regardless of the language they speak, would like some sort of assistance completing that application, just because it's not an easy process. So that is one barrier, is that it's a whole new way of applying for Medicaid. Identity proofing on Maryland Health Connection has been a challenge, especially for immigrant populations. Naturalized and legal permanent resident populations are not easily verified by the federal data hub, which is how Maryland Health Connection reaches out and identity proofs someone. And so also hyphenated names have come back as not able to be verified as well, unless it's entered exactly the way that it is in the federal hub. So what we're seeing are a lot of folks in the immigrant community who are not able to have their identity verified and have to come in with a proof of ID that someone has to manually verify for them. There's also confusion about who to identify as a household member, especially in households with mixed immigrant status. And the answer is everyone. But also there's multi-generational households. So there's some question about who makes up a household. So do you include parents, grandparents? So that the question of there's 10 people, multi-generational house, who's included on my application? That's a question that impacts especially this population. And there's also technical and volume issues around processing verification. So a lot of people who have not been able to have their information verified are granted a period of temporary eligibility for Medicaid. And what we've seen is that the verifications are not being processed in a timely manner on the back end. So someone may find that their coverage has ended even though they've provided documentation. So these are just some of the challenges that we're seeing. And so I bring these up without actual solutions, but I do want to just let you know that HCAM has our own call center. So we are able to look into CARES and look into Maryland Health Connection and try to unravel a case for you. So if you're working with a consumer who comes to you with a notice and they're not really sure what it means, or it says, please provide this information, and they've already provided it, and you just need assistance checking kind of in the back end of some systems to find out what the status of an application is, we are available. We have a call center that is staffed with certified navigators. And so you are welcome to call our call center, and we can certainly assist with some of your cases. And I just want to give the little caveat that if you are calling about a Medicaid case, we may not be able to give you the answer right then and there, but we will have to research and get back to you. So I just wanted to mention that the turnaround time of 2 business days is about what we've been seeing to get that information and get it back to you. So I'm going to end there, and I will be happy to take questions after Shannon's presentation.
Hi, good afternoon, everyone. Hi. So I'm Shannon. I am here officially representing the Baltimore City Health Department, but I'm actually going to be talking about some of the work that I did in Pennsylvania prior to moving to Baltimore, and I think it's a good follow-up to Lena's presentation, because what I'm going to talk about is a model that's called medical legal partnerships, and these are collaborations between lawyers and healthcare professionals to address some of the root causes of poor health. It's a model that I'm trying to get off the ground in Baltimore City in some ways, but I'm going to have to reference some of the work that I did in southeastern Pennsylvania, but that is very relevant to this conference. So I'm going to give an overview of what medical legal partnership, or MLPs, are. Talk a little bit about why legal needs are health harming, talk about the value of these partnerships, and then we'll have time for question and answer after. So the basis for medical legal partnerships is something that I'm sure most of us in this room are very familiar with, which is the idea that it's really where we live, work, and play that determines our health status. It's largely what happens outside of the hospital and the doctor's office. And we know now research is being done to actually quantify the factors that affect our lives and our health. And as you can see, only about 10% of what impacts our health is that clinical care. Another 10% is just accessing care. But it's really the social and economic factors, the physical environment, these things that happen outside the doctor's office that are determining our health status. And we know that these social determinants of health are very critical, and this is what leads to the disparities that we see in outcomes in our city. So in light of the recent events in the city, the life expectancy gap of Baltimore has been discussed quite a bit. We live in a city where just a few miles apart means a 20-year life expectancy. And we know that the reasons why this huge gap exists is due to those social, economic, political, and environmental factors. But when we look at what we value and pay for in healthcare, Even though we know that about 90% of what impacts our health happens outside of the clinical office, we're spending about 97% of our dollars on those clinical services. Only about 3% of our total U.S. healthcare budget is being spent on non-clinical care, addressing those social determinants of health. But that's all very negative. We are at a time right now where healthcare is transforming. We live in the state of Maryland where there's financial incentives to start really putting value and resources into care that really helps folks improve their health status and starts to address those root causes. So why am I talking about lawyers? Medical legal partnerships, like I said, are collaborations between lawyers and healthcare providers that meet individuals' legal needs. It transforms the way that healthcare is delivered, and it also allows for opportunities in which healthcare providers, social workers, nurses, doctors, and lawyers work together to identify systemic issues and change policy that impacts entire communities. So why a lawyer? Civil legal aid attorneys remediate health-harming legal needs that include poor housing conditions, accessing basic necessities, accessing health care, improving financial stability, and improving family stability. And as you've been discussing all day today, and Lena definitely pointed out, the legal needs of immigrant populations are especially unique and critical, especially when you're thinking about accessing health care. Because the Affordable Care Act, so much left out the undocumented population, and there's so many additional barriers in our country to access health care and to access basic necessities, including language accessibility, discrimination, and then of course family stability issues as well. So we know that lawyers exist in our country. We know that doctors exist in our country. Why do we have to bring the two together? Well, we have a huge gap in access to legal services in our country for poor people. So in 2012, fewer than 1% of all of our attorneys were legal aid attorneys. This leaves a huge gap for individuals in meeting their basic needs. Because when we're talking about unmet legal needs, these are the needs that are very proximate to just living lives that meet basic necessities, right? We're not talking about corporate law here. We're talking about safe housing, getting to the doctor, having transportation. So approximately 80% of the civil legal needs of low-income individuals go unmet. And this slide has a lot of numbers, and I always read it wrong. So individuals who are at 200% of the poverty level or below, there is one legal aid attorney for every 14,229 people. For people who are above 200%, it's one attorney for every 217. So it's a huge gap. And if you're at 200% of the federal poverty level, you generally cannot afford a private attorney. So when you look at that math at 400%, you see the disparity is even greater. There's only one legal aid attorney for every 27,578 people who are living below 400% of the federal poverty level. So the work that I'm going to reference is a medical legal partnership in Chester, Pennsylvania, which is a small city right outside of Philadelphia, a very high-need area. A lot of the resources that are available to Philadelphia are not available to Chester. And we have a medical legal partnership in 2 maternal child health settings, Healthy Start, which serves the needs of pregnant women or women with children up to 2, and Nurse Family Partnership, which is a home visiting nursing program. The way that this works in the city of Chester is that our nurses, our social workers, and our lawyers sit in the same office, so they're fully integrated. Our lawyers and law students conduct trainings with our social workers and nurses and train them on how to identify unmet legal needs, how to advocate for clients, do some basic training around the law. For example, a lot of the changes due to the Affordable Care Act and eligibility. Every client is screened for unmet social and legal needs. When a client screens positive, they're referred to an attorney who follows up with the person within 24 hours. The attorney resolves the legal case the best she or he can, and then we follow up for evaluation purposes to make sure that the client and family got what they needed. So for the first 3 years of our project, we were able to serve over 300 individuals and their family members. We addressed 187 legal cases. In addition to the individual representation, one of the values of a model like this is that everyone learns from one another. So the lawyers learn from the social workers and the nurses, and they learn from the lawyers through these case consultations. And about 151 of those were documented. We were able to train 38 students from multiple disciplines, including students who were bilingual. And we did 34 trainings between staff and community partners. To give you an idea of some of the legal issues that were resolved, public benefits was about half of the work. And a lot of what I would classify our immigration cases as are also public benefits issues due to the challenges in accessing insurance coverage. So a lot of emergency medical assistance cases, navigating the public benefit systems. We also see a lot of disability benefits cases and a lot of housing cases, utility shutoff, custody issues, and consumer issues, which we define quite broadly. And I think sometimes the connection between a consumer law issue and a health need to some folks who are not thinking broadly about health seems quite attenuated. But to give you an example, we had a family, a mom who had 8 children, who bought a van, and there was basically fraud in the sale of the van, and the van was broken, and she didn't know that. And though we had limited legal redress to resolve that issue, our consumer law attorney was able to resolve the issue and get Mom her van. Well, in the time that she didn't have transportation, she had 8 kids with asthma who were not making it to their appointments. So I think it's the stories like these that we have to tell to really make the connection between these social and economic issues and health. So through our program evaluation, we have seen reductions in participant stress, improvements in sleep, improvements in overall health, increased self-efficacy, meaning that our clients feel more assured and advocating on behalf of themselves. We are starting to do a more rigorous evaluation. This evaluation was all self-report, but it was all extremely positive. And one of the very unique values of a partnership like this that brings 2 seemingly different fields together is the impact that it has on communities through systemic advocacy. The example that I'll talk about has to deal with the impact on immigrant populations specifically. So in the city of Chester, the Department of Public Welfare was sending all of their notices to individuals in English only. This violated their own policy in the law. We were able to represent, well, first, our social workers were able to identify that this was happening and report it back to our attorneys because they noticed a pattern. We were able to represent clients and then make the local welfare office make sure that they were complying by their own laws in sending out information to Spanish-speaking clients in Spanish. And again, this has a huge impact on health, right? If you're receiving notices that you need to re-verify your status or you need to provide additional documentation and you can't understand what you're receiving, you're cut off from your benefit. So this was an issue that had an impact on our entire community. Similarly, during one of the hurricanes, folks lost their electricity. The local SNAP office, their food stamp office, was refusing to reissue food stamps. The folks who had just used them to buy food lost it because their refrigerators weren't working. We were able to identify a few cases, and we demanded that the local SNAP office actually reissued food stamps to all of the folks who were in the community receiving them. So this was another example of where we had 1 or 2 cases. We knew it was impacting more folks. And because for whatever reason, folks start to listen when you have a lawyer on board, we were able to really make an effective change that helped numerous people. Similarly, collaborations like this that are multidisciplinary are really changing our healthcare delivery system. And we've measured this through pre and post tests and interviews with staff. And we found that healthcare staff have really reported increased knowledge about legal issues and screening for legal issues, and increased capacity to serve their clients, because our social workers who were dealing with issues for months on end and could not have a resolution, with having the assistance of their attorney partner come in, the resolutions came much quicker. It increased their advocacy capacity, it decreased their stress, and like I said, increased their ability to identify and refer for legal needs. And the picture is Joanne Craig, who's the head of our Healthy Start. I needed a filler on the page and figured I would use her image. Thank you. So I know everyone in the room is like, this is great, but it sounds like it costs a whole lot of money, and who's going to pay for a lawyer as part of a team when, you know, resources are limited. So these medical legal partnerships, which are nationwide in various capacities, have actually resulted in really high return on investment. Because if you have folks who are part of your healthcare team that are helping individuals, and this is just one example of a financial return on investment, and there's others, but as a healthcare provider, if you have staff who are helping to get your patients insured and you're getting reimbursed, it's an investment worth making. And medical legal partnerships, as you saw, 50% of the work we did were public benefits, and a majority of that was Medicaid. And I know my time is up, so thank you. And I know that was a lot of information, but I guess we have a few minutes for questions.
Thank you very much, Lena and Shannon. There was terrific presentations. We heard from Lena just how the system works and how Healthcare Access Maryland is making it work for people. And we heard from Shannon just about an innovative new program, which we hope that Shannon can bring to Maryland. Again, I'm Vinny DeMarco, the head of Maryland Citizens Health Initiative, and we are proud to be working closely with the Baltimore City Health Department and HCAM to make sure the Affordable Care Act is fully implemented in Maryland. We are making progress. We've gotten over 400,000 people health care, and in Maryland we had 300,000 people health care even before that. So a lot of progress has been made, but what you're showing today with this conference is a lot more needs to be done. And I want to just introduce my colleagues, Stephanie Clapper and Sarah Felipe, who've been here all day with you and bringing back ideas, and we want to work with you. But first I want a big hand for Monica and Sarah for all the work you do, and thanks for having us here and for putting on this great conference. But now it's your turn to ask some questions of our two great panelists and see what they can tell you about what they talked about. You have questions, comments? Tell your name and tell us your question.
My name is Flor Justi, and I'm a social worker, and I have been working in the Latino community here in Baltimore City for the past almost 20 years. And I think some of the panelists already have heard me, but I want to raise the issue again in terms of access to healthcare, because I work with a lot of immigrant families that are mixed families, and applying for medical assistance to renew the medical assistance of the children when the parent is undocumented is not possible to do through the online webpage. If it has changed in the last week, it will be great, but as last week, if you don't have a valid social security number, you cannot go through the application. And that is something that I strongly feel needs to be addressed, especially to simplify things for people who want to apply for medical assistance for the children. The other problem that I'm encountering, and I hope that I'm raising the issue because I think it's important to at least listen from the consumers. is that the letters that the people are receiving once they apply for medical assistance is one letter that says, we have reviewed your application, you are eligible for medical assistance, or your child is eligible. And the second letter is, you are being approved for this, since this date, but no number. And I have not been lucky to get somebody to give me the medical assistance number for large periods of time. And working on improving the application process for medical assistance is something that is really, really important. And especially, specifically for these people who are families with undocumented parents. And also, who is the head of household? That's another big issue, because in a lot of the Latino families who are traditional families, dad is outside working and mom is taking care of every decision. So I'm always very strong about mom is the head of household, because she is the one who is making all the decisions. And I found that sometimes when people go to apply to the HCAM office, the navigator is deciding for the family that because dad is who is earning the money, he should be put as the head of household. And that complicates every decision afterwards. So those are a couple of issues that I want to raise. And I also want to make one comment about the program combining legal and health issues. I think it's a wonderful idea. And I just want to make a suggestion. If it's going to be implemented here, legal aid needs to know that it's a special program, because in Baltimore, legal aid only works with people who have a valid social security number. So if it's going to be implemented here, it would be important to keep in mind that there has to be a provision for legal aid to make an exemption and be able to work with families who don't have a legal.
Thank you very, very much. Shannon, you want to take that first, and then Lena?
So you're absolutely right. Certain legal aid organizations are funded by the federal government, and they have restrictions on who they can represent. One of the values of this medical legal partnership model is that when we could get healthcare providers and private philanthropy and other folks to fund it, there aren't those restrictions. So largely the legal aid organizations they have federal regulations that they're abiding by. Our project, we don't have those restrictions.
Thank you, Shannon. Lena, did you want to address some of the other issues?
I mean, we've spoken with Laura about this before, so we are doing what we can to address them, but a lot of these are systemic issues that need to be addressed by the system and the exchange, so we're advocating on behalf of that, but you know, it's a huge expensive technical system, so change is not always very quick.
Yep. Thanks, and I think HCAM is doing a great job in getting the system to work as well as it can. Anybody else?
I'm just curious, and again, this is probably an ignorance of my behalf, but why is it important to put everybody in the household when you are applying for any qualified health care or Medicaid, that other people that are probably are not documented need to be there? Is there a reason for that?
Yes, because eligibility is based on household income, so you need to have the number of people in the house and the whole household's income in order to determine the program for which your family would be eligible for. From whom? I think more confusion than pushback, because a social security number is required, and so the only way you can get around doing that is by indicating not applying. So I wouldn't say pushback, but I would say that someone would very much need a navigator to sit and walk them through the process, because it's not easy to navigate on one's own.
Thank you. Sarah.
For Lena, who makes the decisions regulating, for example, that emergency Medicaid applicants stay in the legacy paper program as opposed to the, being able to do the Maryland Health Connection? So so is that a state or a?
Yeah, it's DHMH in conjunction with the exchange.
Okay, and is there any plan is there a phase out for the paper?
Yeah, so I think the long-term goal is to have all entitlement programs incorporated into Maryland Health Connection so that you won't have this dual system. I think as of now, almost every type of Medicaid case that was processed in CARES is now processed in Maryland Health Connection. The only exception is really emergency Medicaid and age-blind and disabled. So at some point, you're going to see every entitlement program, including food stamps and cash assistance, included in Maryland Health Connection, but it's only the first year of using the new platform, so I imagine it'll be a couple years down the road before that starts to be pushed over.
And I think we can understand there will be growing pains as we get into this new system, but it's a lot better than the system that we had. Other question?
Yes, my name is Libby Arcia. I work for Health Leads, and actually this is a suggestion for Lena regarding the applicants with the mixed families being so difficult and expensive to navigate through the internet. Would it not be less expensive and more cost effective to have the community navigators work year round, especially like community organizations like Esperanza Center and CASA who serve these populations, so that it would facilitate their recertification and application process?
You mean the navigators?
Mm-hmm.
The navigators do work year round.
At Esperanza?
So they may not, so just to give you some background, we have a grant from the state. It is being cut 40% for FY16. So right now in FY15, we have 46 navigators. We have 11 partners who have assisters that they've hired with money that we've granted them. Well, next year, we are going to have half of our funding, basically. So our resources are being pushed, and we also have satellite sites in Pasadena and Reisterstown that we have to staff. So yes, we would like to have full-time navigators in every location across all of our region, but that's just not possible. We really have to prioritize where we put navigators. And during open enrollment, we focus on those locations where there's going to be qualified health plan, a qualified health plan eligible population, because those 3 months of open enrollment, that's the only time that that population can enroll in QHPs other than a special enrollment period. Then now that we're outside of open enrollment, we're focused on more Medicaid eligible locations. But again, I do want to emphasize that we have limited resources. So even as it is, we may have a navigator 1 or 2 days a week in a particular location because we have to move navigators around. So we would love to have full-time navigators, but we're just not able to do that, and we'll be even less able to do that next year. And so one thing that we are going to be working with our former partners and reaching out to people who are informal partners throughout the region is to increase their own internal capacity by applying to become application counselor sponsoring entities. And in doing so, the organization can apply through the exchange to be an application counselor sponsoring entity. They can send their own staff to certified application counselor training to be certified and learn how to do enrollment in both Medicaid and qualified health plans. Through the exchange, they would be certified to assist their own consumers. So we're going to be facilitating getting as many groups as possible certified so that they can build their own internal capacity, just because we are not able to provide a navigator for every location that would need one.
That's a very good backup plan. I think we have time for one more question.
This question is for Lena. When a pregnant woman, undocumented, applies for emergency medical services, labor and delivery, she applies she applies through the Maryland Health Services. Yeah, and she's receiving SNAP. Why does the application go through then Department of Social Services?
Now we're getting into the weeds, and I can talk about this offline, but if someone is applying for Medicaid as well, emergency Medicaid as well as SNAP or TANF, that is a case that DSS has to handle. It's called an associated case, where they would handle the enrollment in all of someone's benefits. So if someone goes to DSS and applies for SNAP or TANF, DSS is the only place that can handle those. And then if, for example, the person were to go to the health department and apply for Medicaid, the health department would see that they have an open DSS case and would have to transfer that case over to DSS so that it could all be handled at once. They would actually not be allowed to process the case. So it's a complex system with DHR and DHMH, and it's not super efficient, but that's how it works.
Does everybody receive a letter of approval or denial?
They should get the letter of approval or denial from DHR within 30 days.
Well, let's have a big hand for Lena and Shannon. Thank you very much. And I think we're done.